Okay, I'm going to review what happened yesterday, Thursday, regarding the case that I gave you. So what I'm going to do is I'm going to answer the question myself as if I was you. So I'm going to answer the question in the way I asked you to, but I'll have to explain what I'm doing, obviously, rather than just come to a conclusion at the end of this. So I'm going to take you through my thoughts about the diagnosis and then the etiology, and then I'll basically put this into a diagram form, so and maybe try to analyse it a little bit more. I understand that the comment was that you didn't really understand my train of thought. The reason I asked you not to say anything other than ask me tests and treatments and questions was because I didn't really want to give you my train of thought. What I wanted you to do was just go through the exam the way you would do with a patient, and at the end of it come to a conclusion. But on the way I had to stop you, and in which case we then go to a discussion as to why you stopped, and then you got my train of thoughts. Now believe me, this is not what you want to do on an exam. You'd rather the examiner just stay quiet all the way through this and not ask you questions, because when the questioning starts is when the trouble begins. So treat this like a patient, all right? Just do what you normally do with a patient and get on with it, all right? Then at the end, do a conclusion. After the conclusion, then we'll have a discussion, but every time I get involved in these things, it gets complicated, more complicated than it should be. So keep me out of it as much as you can. So I'm going to try and go through this. I'm going to have to give you my thoughts as I'm doing it, which I didn't ask you to do. But otherwise, you're just going to see me go, okay, this test, that test, and this is what it is. Actually, I might try that, see how it works out. Okay. So the question was, we've got a 40-year-old man woke with generalised aching in the shoulder about 3 weeks earlier. That improved. It wasn't terrible, wasn't disabling, but it was aching, and it improved up until a week ago. Then he was making his bed and he got a sudden sharp pain in the anterolateral aspect of the right shoulder. And this has been an ongoing problem for the last week. This is what you've got. The pain that he gets is inconsistent with activity. So he can do the same thing twice and it only hurt him the first time and not the second time and so on. So it's inconsistent, but mostly it's about moving his arm. So, make the diagnosis. All right, so the way I would go into this is I've been thinking there's three main things this will be. Tendinopathy, not biceps tendinopathy, but tendinopathy. They all tend to give you pain in that same area. So a tendinopathy, a degenerative labral tear, and an AC joint problem. They're all sort of clustered in that region there. My first thing to do is to eliminate as many of these as I can. Not all of them by any means, because then it gets really complicated, but eliminate the ones that are not likely to be. So, palpation, AC joint and tendons. You can palpate these, and if they're all negative, then it's unlikely to be any of those, which leaves you with a labral tear. So, what we found was, I'm going to do what you did, palpate the biceps tendon first. That was tender. Okay, so I'm thinking now it's a tendinopathy, biceps tendinopathy, and we'll do the contractile test. The contractile test turned out to be negative. Now that's all of them, including stretching, maximal contractions in the stretch position, the neutral position, and so on. So they're all negative, which says that the tendon is unlikely to be the source of the symptoms. So we can worry about that later on, but right now it's not part of our diagnostic scheme. Okay, second thing, the first thing you did actually was to test the AC joint. I'm getting ahead of myself. I'll then look at the AC joint. The AC joint wasn't tender, which is what you found with me, and that leads you to labral test. So now, I'm not looking to eliminate that, I'm looking to prove this. So the tests I'm going to do for this will be O'Brien's and load shift test. The O'Brien's test was very, very positive. It was almost negative. Well, it wasn't negative, but it was painful when I did it in supination, lateral rotation of shoulder. With pronation and medial rotation of shoulder, it was almost negative. So that strongly suggests it's biceps tendon. The lump shift test, however, was negative. Okay, so I can't say this in the label. What I can say is it's not unstable at the moment. If this is a biceps tendon, labral tear, then it's hyperstable, that is, it's subluxed. So really that leaves me with the possibility that this is a transverse ligament tear, which sort of goes with the tenderness of the biceps tendon. It's all the same area. However, I can't prove that at the moment. So what I'm going to do is go back to the labral tear and work on that a bit more and see if I can make something of that. So I look at range of motion. Now the range of motion was limited, particularly when you did it right and isolated the glenohumeral joint from this. So we lost end of range movement. It was painful, and it's difficult to see how a transverse ligament tear or a biceps tendinopathy will limit that movement. So now it takes me back to the labral tear more strongly, and that's where I am at the moment. So what I would do then is manipulate the joint, retest O'Brien's, retest load shift, and what I should find now is, with it being unstable, the O'Brien's test may well be negative, but it may still be positive. But either way, it's positive or negative. In your case, it was negative, but the load shift test was now positive. So we've got this, it's a labral tear. So now we can talk about etiology. Now that took at most 5 minutes, and that's with me explaining what I'm doing, 5 or 6 minutes. So now we can look at, actually it took 6 minutes and 25 seconds. I'm looking at the recording time. So the etiology of this. Now, again, I'm going to talk to you about what I'm thinking about. But this is either weakness of the muscle or direct mechanical stress on the glenohumeral joint, one or the other, or both. It's often both. So if the first thought you had was it's segmental facilitation and you were dying to test the neck range of motion, I gave you the extension quadrant was limited and painful. But that's not your first step. Your first step is to prove that there is segmental facilitation. So you go through and test the segments you're interested in. Now, it's C5-6 for the glenohumeral joint, but you were talking about this being a loss of quality of movement of the scapula, so scapular-thoracic inner harmony being present. Now, that's not C6-7, but this is everything from C4 with levator scapula all the way down to T1. So if you're going to do that, you have to examine for all of those segments. If you're just interested in the glenohumeral joint, which is what I am at the moment, then I'll look at C5-6, and let's say we prove that there is non-fatiguing, non-breaking weakness in the C5-6 segments. Fine. But there's also breaking weakness, which I gave you, of lateral rotation of the shoulder. So that segmental facilitation could be coming from the shoulder or another joint. You don't know if it's caused the problem, that is the destabilizing of the shoulder, or whether the destabilizing of the shoulder has caused the segmental facilitation. Nonetheless, you look for the source, and you do it by screening for nociception. So we can do PAs on the neck, we can push it into the right extension quadrant, see if it's painful. We can look at quadrants for the elbow, quadrants for the wrist, and see if any of that are nociceptive. Then we've got a potential possibility for segmental facilitation to be playing a role, but it may not be. You wobbling the neck does not prove it's a neck. Wobbling anywhere in those segments should reduce segmental facilitation, not just at the segment that the facilitation is coming from. Not the cause of the facilitation, but the facilitation is being mediated at those two segments. Okay, so the other one is direct mechanical stress. Now this can be coming from the upper thorax, so this could be first, second ribs, down to T6 really, but the axis of motion for the shoulder runs about to 3, so you've got to take in at least the first 4 levels. Now, trying to deal with or screen out the thoracic spine and ribs by breathing isn't good enough. You're arguing that your hands are so sensitive you can pick up minor variations of mobility, and it's debatable whether you can do that, especially if the patient is fairly bulky. Plus the fact hypermobility in that area or instability in that area probably will escape your fingers from testing with breathing because it's mobile, it's too mobile. So you're not going to pick it up. So you do something much more reliable. PAs, push on the ribs, see if the end feels good, see if you're reproducing pain. But the other thing you can do is look at secondary reflex inhibition coming from the shoulder. And what we can do now is we can test for weakness from the extreme position. So we can take the arm out, I'll do this arm. You can take the arm into that position and push it down. Now, we know the shoulder's in trouble. We can wobble the shoulder, and then we can test these again at the end of range. Now, secondary reflex inhibition is going to show up almost certainly if I have an unstable or hypomobile thoracic segment. So I can go at looking at this in two ways. I can establish breaking weakness coming from the thorax, or I can examine the thorax. So either way is good. But then in both cases, I need to look at the segments. I need to test the thoracic segments. What I'm looking for here, of course, is loss of extension. If this is an elevation problem, which it almost certainly is, then it's because the shoulder can't get back because the thorax isn't accommodating it. So if you're finding that with your biomechanical examination, there's your etiology, and it may have nothing to do with the segmental facilitation, or a lot to do with the segmental facilitation. What I would do in this case, so is I would treat the shoulder, we've done it, manipulate it, then I would look at the thorax. Hopefully it just needs manipulating, for the moment anyway, for the purposes of diagnosis. And both of these should help. You can wobble to get rid of the breaking weakness as a reflex inhibition, but you can do both of those things. Then you can go back maybe the next visit and see if they still have the segmental facilitation, providing the glenohumeral joint is no longer painful. Now, if the glenohumeral joint is still painful and they still have, is not painful, but they still have segmental facilitation, then you may have to go and look at these joints biomechanically and treat them as well to get rid of that. So this could be one cause, the thorax. It could be two causes, the thorax and the segmental facilitation, or it could just be the segmental facilitation causing weakness of the rotator cuff and biceps and allowing dynamic destabilization of the shoulder. That's it. That took me, I've lost track now, 6:26. That took me a total of about 20 minutes to go through that. This is how it should be. We can move off that now and go on to your next question. If you're dragging this out, then you're going to run into trouble, because essentially, actually no, it doesn't. Essentially, you won't have time to answer the rest of the questions. Sorry, that whole answer took 12, 13 minutes. Okay, if I wasn't explaining what I was doing, that whole thing would have taken me about 6 minutes, maybe. Okay, but doing the test, asking questions, and then coming to a conclusion. So when you're not following my train of thought, you shouldn't be doing that. You shouldn't need my train of thought. That is what you should have done. And that's what's been taught to you throughout the whole of your program from last year and fellowship. And for you guys who are doing certification now, this is what you've been taught, the last 4 modules. So don't rely on my train of thought. It shouldn't be a factor. Okay, so now what I'll do is I'll do this in diagrammatic form, a little slower, and you can see what you think. Okay, so same starting point, right shoulder pain, all of the stuff, non-traumatic, anterolateral pain, etc., etc. So differential diagnosis, you can see there is tendinopathy, AC joint, and either pathology or a dysfunction. But I really want to call this arthropathies, but that you tend to reserve that for arthrosis. But either an arthrosis type of thing, or a biomechanical dysfunction, and a glenohumeral arthritis or dysfunction. So for the tendinopathy, we palpated, we found it was positive, contraction tests were negative, so we know that the biceps is not the source of the pain. So what is it? Wobble. So if we wobble the neck and the tenderness goes away, it's segmental facilitation. We could ignore it basically for the moment. If it doesn't improve, then what we may have here is what I called an incipient tendinosis yesterday, and it just means it's one in the making. And the making of this is probably because this is overworking, simply because the joint is unstable. So it's open to overwork to hold the head back, probably. Now, We move on from that because this isn't part of our diagnosis, and we move into AC joint pathology dysfunction, and again we palpate. Often grinding is brought up in this. It's very difficult grinding the AC joint, trying to get hold of these two little bones in growth, which you can do, but palpation is usually good enough as a quick screen. So again, palpation is negative. It's probably not the source of pain. Move on. So now we hit glenohumeral joint. O'Brien's test was positive. Load shift was negative. Differential diagnoses, labral inclusions. I don't know that you should be calling this a biomechanical dysfunction. It's an inclusion labral of the labrum, the same as a meniscus gets included in the knee and locks the knee. You wouldn't call that a biomechanical dysfunction. I don't think you should call this a biomechanical dysfunction, but it's only a label. So inclusion or a transverse ligament tear. If there's a range of motion loss, then it's almost certainly a labral inclusion because a transverse ligament tear shouldn't do it. So transverse ligament is probably not part of the diagnostic. So we've got a probable labral inclusion. Manipulate the glenohumeral joints. This is a taste and see philosophy. O'Brien's will become positive or negative. In your case, I said it was negative, but it may stay positive, but it should be less. And then the load shift should now be positive, and we've got a diagnosis of degenerative labral tear. It takes no real time at all to do that. One of the things I'm expecting from all of you is some form of processing scheme. You should have a way of organising your thoughts with every case. It's not a matter of I do it differently for a shoulder than I would do a hip. They're all the same. What changes is the detail. Your approach to the problem should be organised, and you should know what it is. Now, this shows you how easy it is when you do organise your thoughts. Look at this. This is the etiology of a labral tear, the possibilities here. Now, you get yourself messed up. Michelle, you got yourself really messed up with this because you didn't have an organised process going on. It doesn't have to be this by any means, but you need a process that works for you, and you need to be developing it now. It should have been developed some time ago, actually, but you need to develop it now if you haven't already got one. So if you look at the etiology, the possible etiology of this is it mechanical stresses or biomechanics or both. It could be neurological, but if it's unlikely to be a neurological cause, except for axoplasmic flow problems. And I'm going to discount those at the moment simply because of what we found. We did look for weakness, and if you find fatigable weakness with no other neurological signs, you've got an AXT flow problem, but we didn't find that. So these are our possibilities. Segmental facilitation. So screen for C5-6 weakness. If you're really concerned about the ability of the scapula to move normally, then you need to screen a lot more segments. You need to go from C4 down to T1 at least. So we're going to screen for C5-6 for weakness. If we find it, we've got segmental facilitation. Of course, you don't know where it's coming from. You don't know if it's coming from the shoulder or if it's coming from another joint or both. But you have a potential etiology of caused by stabilizer weakness. Okay. So we can screen for nociception, and we may choose to treat. Okay, not necessarily though. The other possibilities is the mechanical stress, reflex inhibition. Check the shoulder quadrants for breaking weakness. If it's found, screen for ribs and spine, or the other way around. Screen for ribs and spine to see if they're dysfunctional, and if you find that, then check for breaking weakness. It really doesn't matter which way where you do it. But if you find both of these positive, you again have a potential etiology where this is now not so much, I copied it over, this is not so much stabilizer weakness, but direct mechanical stress. You do a biomechanical assessment on all of the joints you found nociceptive, and the thoracic spine and ribs, and if they're positive, then you can do your biomechanical treatments if you think it's necessary. As I said, basically your real weakness here is the segmental facilitation. Is it coming from the painful joint, which it will be, or are there other joints that are contributing or actually cause this problem? And that we don't know. So my thought would be, don't treat the segmental facilitation directly. The stuff you find nociceptive, don't treat it yet. treat the ribs and the shoulder and see what happens. Both of those do need treating, so treat those and see what happens. And if you need to then look at the cause of segmental facilitation, do so. Okay, so let's put all this together then. And again, you can see how simple this actually is when you have a process in place. So we start off over the top left-hand corner there. Let's get a laser point on it. And we've got anterolateral shoulder pain with all the causes and everything else we've done. We found that biceps were tender, the contractile tests were negative, and the range of motion tests were positive. Elevation was slightly limited and painful, and posterior glide was restricted. This is what we found. So we do O'Brien's test, and we found O'Brien's was positive, but the load shift test when we did it was negative. We manipulated the glenohumeral joint, and we found that O'Brien's was negative in this case, and the load shift was positive. Remember, the O'Brien's test may have stayed positive. So we're now saying it's a degenerative labral tear, because the only other thing it could be is a transverse ligament tear, and the range of motion sort of says it's not. Anyway, we've got both of these positive. Now the load shift is positive, O'Brien's is negative or positive. Both of these say the same thing. So we can do the C5-6 segmental facilitation. You find it, screen for nociception. We found it was positive for neck problems. Do a biomechanical diagnosis in the neck. But don't forget, do it all the way through C6-7. I'm doing this for simplicity's sake. And then we can screen for the thoracic spine by looking at the doing PAs and so on it, and then looking at the biomechanical exam, and we can look for breaking weakness at the shoulder, in the shoulder quadrants, or we can do that the other way around. This will give us a diagnosis of a dysfunction at the thoracic spine that potentially could be causing the problem, and now we can do a biomechanical exam of the thoracic spine if you haven't already done it, and then we can treat the thorax if we decide to do so. It really is that simple. You just need an organised process, and it doesn't have to be mine by any means, but you've got to understand what's going on here. If I'm asking you why, how does segmental facilitation cause instability of the shoulder, you should be able to tell me without any hesitation at all. You should be at the point now where you shouldn't be nervous about saying what you think is true. The fellows, that is. Don't be nervous, say it. The worst that's going to happen in this case is you're going to be wrong. If you do this in the exam because you're frightened of making a statement, then you're going to be failed. There's a difference between the two. One is inconsequential, the other one has huge consequences. So say what you're thinking and say it quick and say it and get it done. Don't hesitate over this. And please organise your thoughts, because it's the only way to practice. So I hope that helped. I don't think that my thought process is that difficult to follow. Essentially, what you've been learning all this time are the way I think and the way most other people in impact think about things. But nobody's identical. We've all got differences, and you're fine to have differences. Your processing could be different, your organisation of the information will be different. It doesn't really matter. But if you haven't got a process that you use on a regular basis, and you're just haphazard with the way you approach patients, you're going to run into a lot of trouble, because each patient is different and you're going to be going at this in different ways all the time, and you won't have an habitual process and system in place. Because when that goes wrong, you can then say, okay, we've done everything I normally do, now let's look at the things I don't do. And you can't do that if you're not organised in that way, because you have probably forgotten what you did do in the first place. So principles, not detail. Individual patients' complaints don't really matter when it comes to processing. You know what you're looking for, you hypothesize it, prove or disprove the hypothesis, and move on to the next one. But be organised as you do it. All right, guys? So we'll do this a few more times, and you'll get better at it. Okay, take care all. Bye.